Good evening, everyone. Today I am presenting my case of Mr. X, 39 years old, Hindu married male, hailing from Janakpuri, Delhi, businessman by occupation, and I admitted in our hospital on 28th of December 2022 with chief complaints of swelling of bilateral lower limbs for last 6 months associated with facial puffiness and frothy urine. In the history of present illness, 39 years old male with no previous history of comorbidities presented with swelling of bilateral lower limbs for 6 months duration, which was insidious in onset and gradually progressive in nature. First noticed around the ankles, which gradually progressed to involve the thighs. Swelling was pitting in nature. There was no associated history of pain, redness, or any discharge from the swelling. It was also associated with facial puffiness, which was restricted to periorbital region, more pronounced during morning hours and gradually subsided towards the evening. There was also associated frothy urine, which persists after flushing the toilet. There was no history of any other urinary complaints like decrease in urine output, hematuria, cola-colored urine, or nocturia. No history of shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, cough, palpitation, chest pain, or hemoptysis. No history of abdominal pain or distension, jaundice, or GI bleed. No history of fever, sore throat, or symptoms of upper respiratory tract infection or skin infection. No history of rash, photosensitivity, oral ulcer, alopecia, or joint pain. No history of polyuria, polyphagia, or polydipsia. No history of altered bowel habit, decreased appetite, weight loss, generalized weakness, or easy fatigability. No history of body pain or backache or excessive sweating. No history of hearing loss or visual abnormality. No history of regular intake of any over-the-counter drugs or indigenous or herbal medication or any drug abuse. No history of allergy to dust or pollen grains. No recent history of immunization. He consulted a local physician where he was examined and investigated, and he was told that he was leaking a large amount of protein in his urine. There was no other any abnormality in his physical examination or routine lab test. He was referred to nephrologist, and on further evaluation on passes of protein in urine, he underwent renal biopsy, which was unavailable.
Yeah, carry on. Anything else in the history? Past history?
In the past history, he is not a known diabetic or hypertensive. There was no history of tuberculosis or blood transfusion in the past, no history of similar illness in the past, or no history of any major surgical event in the past. In the family history, he was the first child born out of consanguineous marriage. He lives with his parents and 2 brothers and wife, and all are enjoying good health. No history of hypertension, diabetes, or tuberculosis in the family. No history of kidney disease in the family. No history of similar illness in the family. And personal history: he is non-alcoholic, non-smoker, taking mixed diet. His sleep, appetite, and bowel habits normal.
Right. So anybody else would like to ask anything else in the history? So yeah, we'll start with you. What comes to your mind from whatever has been presented?
Sir, seems to be a case of
Keep sitting.
nephrotic syndrome.
Right.
Adult onset.
So syndrome wise, you would think that it is nephrotic syndrome. So why do you think it's nephrotic syndrome?
So because there is a complaint of anasarca and leaking protein in urine as per the history, and although we don't have the full pentacts about the lipid abnormalities and all, but
So that is investigation anyway. So based on the history, we are just talking
history.
So one, you think this as far as the syndromic diagnosis is concerned, nephrotic syndrome. Any differential?
Sir, can be adult onset minimal?
No, that's nephrotic syndrome. So then you come to the etiology. First of all, syndrome wise, is there anything else that you want to think of, or you think that nephrotic syndrome is?
Sir, I would syndromic. Sir, I would keep it as nephrotic only.
Okay. Anybody else in the audience with any different views? Alright, we come back to you. No, only I think in the history hypertension is there or not?
No,
No. Okay. So you're presenting here. This one? Okay, so over to you then. What is your possibility?
Sir, my patient is probably gradual onset edematous illness, probably of nephrotic syndrome, and probably of primary glomerular disease.
Okay. So now, so in other words, idiopathic nephrotic syndrome or secondary?
Idiopathic.
Idiopathic. So what are the possibilities that come to your mind in this
Sir,
39-year-old?
as a patient is of 39 years of age, my first provisional diagnosis is membranous nephropathy,
Okay.
followed by focal segmented glomerular cirrhosis.
Followed by focal segmental glomerulonephrosis. So these are your two possibilities, right? Okay. And obviously biopsy
Minimal.
done will come to. Minimal change you want to
Yes,
keep?
sir.
No. Yes, no.
Yes.
Then mention that. So any particular reason for keeping membranous as number one? Why do you think membranous is the common reason?
According to various studies conducted in the North Indian region, adult onset nephrotic syndrome is mostly found to be of membranous nephropathy origin, followed by focal segmental glomerular cirrhosis, and there is no history of hypertension or no history of any renal failure. So I would like to keep membranous nephropathy as
Okay.
first diagnosis.
FSG, which study are you quoting with, and what are the percentages of membranous versus FSGS versus minimal change?
Membranous around 35%.
That no doubt is. So membranous, I think no doubt it's the commonest cause. So now second you have kept focal segmental glomerulonephrosis. So that's why my question is, what is the FSGS? And you have kept third as minimal change. So FSGS second and third minimal change. So which studies are you quoting there?
So
And
in the
how
PGI
common is FSGS?
PGI Chandigarh, it was done in 2014. They found that there is changing histological pattern in adult nephrotic syndrome. FSGS percentage is rising than minimal change.
You're right. But still, I think if you look at other series, minimal change is still the commonest in a 39-year-old. Anything else that would favor minimal change over FSGS? In your
A gradual history of
that's the
issue.
same. Hypertension. FSGS is usually they are
No
hypertensive. So you don't have hypertension. So I would actually keep minimal change based on studies. This one study has shown increasing FSGS. But if you look at all the studies, minimal change is still the second commonest cause after membranous nephropathy. So nobody questions membranous as the commonest cause. Okay. So let's quickly move on to the examination, then we can discuss other things.
In the general examination, patient is conscious, alert, oriented to time, place, and person. The decubitus is of choice, build average, nutrition good. Height is 5 feet 8 inches, weight 74 kg, BMI of 25.6. Blood pressure is 130 by 70 mm of mercury, measured in both arms in supine position without any posterior hypotension. Pulse is 94 per minute, regular, normal in volume and character, without any radioradial or radiofemoral delay, and all the peripheral pulses are palpable equally. Respiratory rate is 18 per minute, regular, abdominothoracic in pattern. Pallor, icterus, jaundice, cyanosis, clubbing absent. Jugular venous pressure is not raised. Limb gland is not palpable. Edema is present bilaterally till the knees, and condition of skin and hair is normal. In the systemic examination, there is no positive finding.
Alright. Urine. The urine is considered a part of your, urine. So you want to tell us what the urine
In urine examination, glucose is nil, protein is 4 plus, pus cell occasional, RBC 4 to 5 per hyper field, Cas is absent.
Alright. So just summarize what are the positive findings in the history examination, and then what's your diagnosis?
My patient is 39-year-old male, presented with gradual onset edematous illness for 6 months duration, with positive finding in the general examination as edema, And in urine examination, it was 4 plus proteinuria, nephrotic range proteinuria.
Right. And your possibilities? Anything different?
Membranous nephropathy is most likely diagnosed.
Okay. So when you talk about membranous nephropathy, what do you think? It's primary or is it secondary?
From the history and examination, there is no clue towards any secondary
Alright.
causes.
So primary
Primary.
idiopathic membranous. Second. Okay, that's your number one. Number two?
Minimal change.
Okay. And number three?
Focal segment.
Anything else? Now what about this microhematuria? Does it favor any particular diagnosis? Go against a particular diagnosis?
Microscopic hematuria is more common in FSCS, but around 30% of cases of membranous nephropathy, microscopic hematuria may be present.
And minimal change, how common is microscopic hematuria?
10 to 15%.
Yeah, about 20%. So it really it's there. And FSGS?
50 to 60%.
50 to 60%. So it is there in all. It doesn't go help us one way or the other. Which brings us to the investigative pathway for this particular patient. That we'll keep the biopsy for the last. So tell us now. He walks into. You are sitting in the clinic. How do you approach it?
So first, I want to quantify the amount of protein he is passing. So we'll go for 24-hour urine protein.
Right. So which you have told us already. It's
7.5 gram protein.
yeah. Then next.
Next, we'll go for kidney function test for any level of creatinine, urea, and electrolytes.
Right. What else?
Then complete blood count.
Okay.
Then lipid profile,
Mm-hmm.
thyroid profile,
Mm-hmm.
and then to rule out the secondary causes, we'll go for immunological tests like ANA,
Mm-hmm.
complements.
Mm-hmm. Complement, but you didn't give a possibility. How is complement going to help you? First of all, before that, I would mention certain other tests. This is more to exclude.
PLA2 receptor.
Okay, anti-PLA2R. Anything else? Beyond PLA2R?
Virology,
Okay.
and basically anti-HCV,
Sure.
two secondary causes, stool occurred blood, ultrasound,
Chest X-ray.
chest X-ray.
Right.
These are
So what I was trying to get to is that anti-PLA2R is one antibody that has been now isolated. Are you aware of any other antibody tests?
Yes, sir.
Thrombospondin.
Thrombospondin. Okay, then
Then
yeah. So these three. When you didn't mention these three, you didn't want to do that. They are available. Thrombospondin is clinically available. Even the third one is just been introduced by us. So non kind of and then certainly virology followed by ANA, C3, C4. How you kind of alright. What else?
ultrasound.
Ultrasound, yeah. Why do you want you were very hesitant about the ultrasound? You want to order or no?
Yes, sir.
What do you want? What are you looking for in ultrasound?
So presence of two kidneys, position of the kidney, and any congenital abnormality, any
Okay.
dysplasia or
And kidney size, most
Kidney
important,
size.
yeah, because membranous nephropathy can be present to your chronic kidney disease also. For all you may know, it might be a silent progression. So kidney size, because ultimately the next step, a definitive test is a biopsy, as we are all going to then. All right, so you're done with the kidney size, and then you come to the
coagulation.
yeah. All right, so you've done the coagulation profile. All right, next.
Biopsy.
All right. So you've done a biopsy now. Tell us what the biopsy results are.
In light microscopy, single ray white linear core measuring 0.7 centimeter in length. Section revealed 4 globuli. All of these show moderate thickening of glomerular capillary descent measures. No endothelial or extracapillary proliferation. No necrotizing lesion. tubulointerstitial compartment show no significant tubular atrophy or interstitial fibrosis, no acute tubular injury or interstitial inflammation. Vascular compartment show no evidence of vasculitis or traumatic microangiopathy.
Okay, we'll stop it. So this is a light microscopy picture. So I don't know your name. So you'll have to tell us what else. Do you want any other information? What I'm trying to ask you is, see, when you ask for, you've done a biopsy, you're going to send this biopsy to the histopathologist. So you are going to order, what test do you want on the biopsy? So this is a light microscopy. So what else do you want in this particular patient? Immunofluorescence. Right. So what are you looking for in immunofluorescence?
Maybe spikes or basement membrane.
That is not an immunofluorescence. She's already shown you the technique of it. Now we are talking about immunofluorescence. So what are the
Because it's
what deposits?
complement immunoglobulins complements
Those
the kappa lambda.
Kappa lambda. How is kappa lambda going to help you in membranous nephropathy? Tell me.
Only for membranous nephropathy.
Because that's where we are heading towards. We are all heading towards a membranous nephropathy or at least. So what else?
For membranous IgG
Yeah.
Tissue PLA to KD.
Yeah. And before we move on to the tissue pillar on immunofluorescence, let's say you are sitting in a peripheral area, say in Jhansi you are sitting and your histopathologist doesn't do PLA2. What else would you on immunofluorescence would hint towards a membranous nephropathy? What are the immunofluorescence findings in membranous nephropathy? IgG and C3. If you find these two, these are nearly pathognomic of membranous nephropathy. You ruled out all other causes of secondary. Alright, and you ruled out minimal change. And then as you said, you look for anti-beta. Look for the anti-PLA2R. And what else? Nowadays, all the three are being done. So all the three antibody you like for immunofluorescence. Alright. Now just a comment about the biopsy. What is? Can you go back? That's it. We are still at the light microscopy. Okay. First of all, on light microscopy, what is an adequate biopsy? Yeah. Who said that? Yes. 8. So this is a suboptimal biopsy. You should know that you require about 8 to 10 or preferably 10 grams. Alright. So let's move on to the
IF.
Yeah.
IF4 reveals 4 glomerular, IgG 3 plus granular along capillary loops, IgA negative, IgM negative, C3 2 plus granular along capillary loops, C1q trace, kappa and lambda 3 plus.
Okay.
Immunohistochemistry, PLA2 receptor moderate granular positivity along capillary loops, thrombospondin negative, and overall features suggestive of PLA2 receptor associated membranous.
Okay. Fair enough. Now what about electron microscopy? What's the role of EM in membranous? When would you say that no, now I want EM? Or would you ask for EM? Yes, no, or yeah, this. Sorry?
In case of ID membranous nephropathy, in which we don't find anything in either telem or not clear with iron.
Okay. Especially if let's say the PLA2R was negative, all the immunofluorescence was negative. Other than IgA C3, you would still. That is when you would ask for. You are looking at secondary causes of membranous, which may not be in this particular. Let's say this was a 60 or 70-year-old gentleman, then you would definitely ask for a secondary for an electron microscopy. But immunofluorescence if it is immunologically neutral. All right. Next. Okay, so I think diagnosis, we are all clear. It's a clear-cut, simple case of primary membranous nephropathy. Now tell me that how do you go about managing this patient?
According to Calico 2021 guideline, we classify patient to low risk, moderate risk, high risk, and very high risk.
All right. So where do you place your patient?
High risk.
Okay. Carry on. Yeah. So how would you treat him?
So in the high risk group, we have all the classes should be given optimal management like anti-proteinuric treatment, diuretic, anti-lipid therapy, and anticoagulation according to serum albumin level,
Not,
and followed
Okay,
by
what is- so
immunosuppression.
in this particular patient, what was the serum albumin level?
1.7
1.7.
by bromoprazole grade.
That's fine. So, what are the indications of anticoagulation therapy? Which are the patients? Why don't you tell us which are the patients you would use anticoagulation? What anticoagulation?
Sir, if less than 2.5, then we have to give for arterial surgeons. More than 3, then we have to stratify the risk. According to the, there's a tool, sir. There's an online tool which we
Right.
do the reading and then we.
So, in this particular patient, you would put him on anticoagulants in it.
Seems to be.
What anticoagulation? How long?
So we have the options of warfarin. We have to take history as well. If there are no high risk features like history of bleed and all, then we'll have to put him on warfarin. Probably till he goes into remission.
No, not that long. It's not a process.
We have to continue.
No, I think, see, the risk is, as you rightly said, below 2.5 is the highest risk. The moment he crosses that and his proteinuria is settling down, you would, even if he is not into a complete remission, you could stop it. But anticoagulants have their own issues. Alright. Now, coming to this anticoagulant, what is the percentage of thromboembolic complications? Which are the complications that you see in nephrotic syndrome? Someone else from the back. Nanji. Yes, the gentleman, you, yeah,
So can you repeat the question, sir?
yeah, thromboembolic complications that you see, how common are they, and what are the common?
So renal vein thrombosis is
Right,
one of the
good.
most common.
Yeah.
So seen in 20 to 30% of the cases.
Hmm.
And besides that, sir, the less common one would be the CNS thrombosis.
Before that, but before deep vein thrombosis was
Deep
very,
vein
very,
thrombosis.
yeah, yeah. Now, what makes you suspect renal vein thrombosis in a particular patient? What are the clinical presentation of a renal vein thrombosis?
So sudden onset frank hematuria,
Okay.
pain, abdomen and tenderness.
Yeah.
So besides that, so these are the two common features, and otherwise,
And worsening of renal function.
worsening of blood pressure.
And renal function,
Yes.
bilateral if you are having, especially in case of bilateral,
And urea.
you can develop anemia. Alright. And how common are thromboembolic complications? Sorry, what was the percentage you mentioned? Overall, let's say all membranous nephropathy.
So overall, it's around 10%. Sir. No, I'm not sure, sir, about the overall.
10 to me.
20 to 30, I'm not sure. I'm not sure.
30 to 50. 30 to 50, no. Far lower. I think the figures are between 1 to 5. I don't know. You've looked at
Around 40%
40%.
in membrane.
Maybe we are talking to the severe group, yeah, but if you look at all membranes, maybe. Okay. Alright, so what are the other complications these patients? So one we talked about thromboembolic complications. What are the other complications these patients can develop? We're talking about nephrotic.
Infection,
Okay. So what are the common infections?
urinary tract infection, pneumonia,
Okay, more common than that?
cellulitis and
Cellulitis,
peritonitis.
peritonitis, yes. Now why do the patients of nephrotic syndrome develop peritonitis? And which is the commonest organism?
Streptococcus.
Streptococcus pneumonia, yeah, that's the commonest. Followed by gram negative. These are the two commonest things. So what makes them predisposed to develop?
Urinary loss of immunoglobulin,
Yeah. Which particular one?
IgG,
Not exactly. Yeah, yeah. Definitely. So that is the sequence of that. So I think there is a complement factor that is involved in.
complement factor B.
Yeah, that's the
Properdin.
one. Yeah. Properdin factor. That is specific defense for pneumococcal infections, and that's why they develop peritonitis due to on the step pneumonia. Alright. Okay. So we are done with infection, thromboembolic, then what else? What are the other complications?
Dyslipidemia.
Okay. Well, dyslipidemia is actually part of, the symptomatic diagnosis. So, okay. What else?
Malnutrition.
Not really, unless it's. So one is progression of the disease and placental transformation. How common is that in membranous? It's a rare complication. So, but yes, they can develop. So this is something we should watch out. Okay, so we've discussed complications. Now coming back to your index patient. So you said you would put him on diuretics, definitely you would give anticoagulation, dyslipidemic, antiproteolytic drugs.
And immunosuppressions.
Okay, so coming on now to the immunosuppression. So he's sitting in front of you. What is your prescription for him?
We can go for polycyclic regimen or rituximab or.
Now, what is the prescription? Then you have to justify. We can't. With the patient, you have to tell him that look, this is 1, 2, 3. This is my choice of immunosuppression. He can then ask you that what are the other alternatives as a patient. I have all the right in the world to ask. Okay, are there any alternatives? So which is the currently?
So rituximab is the
first line therapy. Why? Are there any? What trial are you talking about?
mandatory trial.
What did mandatory trial show?
So in the mandatory trial, rituximab was compared with cyclosporin, and it showed at 12 months there is similar, at least non-inferior to cyclosporin, but at 24 months it is superior to cyclosporin.
In terms of side effects also, more in terms of. But now we are talking, is there any head-to-head trial of Ponticelli?
RI cyclo.
Yeah. So what did that trial show?
Ponticelli is better than rituximab.
So in the 39-year-old, you have to see, you have to tailor the therapy to the risk profile of this patient. So in the 39-year-old, I would still go with Ponticelli because he's likely to tolerate. The cost is less, and the only reason why rituximab has been elevated to as an alternative is because of the side effect profile. So if we have a patient who says 65-year-old and I am not very comfortable, or the patient says that risk of infection is malnourished, is very severe hypoallergenia, there you would perhaps try rituximab. But by and large, I think Ponticelli would be okay. Now tell us what is Ponticelli therapy and what is the modified. What is the original Ponticelli treatment? What is the modified Ponticelli?
Original Ponticelli therapy, chlorambucil was used along with steroid.
Yeah.
6 months therapy, alternating months of steroid followed by chlorambucil.
Alright.
And in modified Ponticelli, in place of chlorambucil, cyclophosphamide is used.
Right. And what are the results for currently? Everybody goes for a modified Ponticelli. Nobody is using the original Ponticelli therapy, right? So what are the long-term remission rates with this? Yeah. Second person, just next to you, you have already done this. Remission rates with Ponticelli.
80%.
At what? 80% at what? 1 year, 5 year, what is the remission?
So at the end of 6 months of
At the end of 1 year, so 6 months, yeah. And 5 years, what is the long-term remission rate?
65 to 70.
Yeah, 60, that's more or less. So what are the side effects now? Say you have started. Would you like to tell us what is your exact prescription of Ponticelli? What would you tell?
In 1, 3 and 5th month, initial 3 days of the month with IV methylprednisolone 1 gram per day, followed by oral prednisolone 0.5 mg per kg per day.
Okay.
And in 2nd, 4th and 6th month, cyclophosphamide oral 2.5 mg per kg per day.
Alright. And what are the side effects of Ponticelli that you would like to monitor?
Pancytopenia, leukopenia,
Right.
and in long term malignancy and infertility.
Okay. So what is the cumulative dose of cyclophosphamide
For
beyond
infer-
which? Huh?
For infertility 10 gram
Yeah.
and for malignancy 25 gram.
What other complications do you see with cyclophosphamide? Rare complications? But also. Hemorrhagic cystitis has been reported more with intravenous, but even with oral they are reported. And more common than that, the commonest
Nausea, vomiting.
oral you don't see. In fact, hair loss is the commonest that you would see. Alopecia is the commonest, followed by this cytopenias. So these are the two side effects. Now we come to rituximab. Let's say this patient says that I am concerned about infertility, although you are telling me 10 grams is there, but I don't want to take a chance. So the rituximab, what dose, what protocol would you follow?
1 gram for 2 doses, 2 weeks apart.
All right.
Then we'll monitor pH.
And the other advantage with rituximab is that it's relatively steroid free. Whereas with Ponticelli, you would end up giving steroids. So a lot of patients would say that I don't want to take steroids. And what are the other complications of therapy with coming back to the Ponticelli with steroid? What are the steroid side effects that you would like to monitor? So you put this patient on Ponticelli. Now on follow up, what would you monitor this patient?
Hyperglycemia,
Okay, good.
weight gain,
Yeah. What else? Steroids, we are talking about steroids. Somebody mentioned? Bone, somebody mentioned it? Osteopenia, osteoporosis, yeah. So how would you evaluate for osteoporosis or osteopenia?
DEXA scan.
DEXA scan, okay. So if you've done a DEXA scan, what do you look at the DEXA scan? What readings does it give you?
T-score and Z-score.
Right. So what is T-score, what is Z-score?
T-score compares to normal same age and sex, and in the Z-score
T-score is against your standardized
against the normograms that are there, right? This is age and Z is Z-score. Age and gender is a Z-score match. All right. So what are the readings that when would you say osteopenia? How do you define osteoporosis?
more than -3.5 is osteoporosis.
2.5. 2.5. And below -1 is osteopenia. So what are the treatments? Let's say that in the third month you have done a bone density scan and you see that this patient is already falling at 2.5. So what treatment would you use? No, not you was it. Sorry. Yeah, you. Yeah.
Calcium supplement, vitamin D supplement.
Okay, good. So you'll give calcium, give vitamin D, what else?
Bisphosphonates.
Bisphosphonates. How much, how long, what prescription would you use? Anybody else? Like you had it, yes, the corner. Yeah. You can, yeah, please. What bisphosphonate? How long? Okay, anybody?
150.
Sorry? Zoledronate, how much? 150?
Per month, 4 mg is
4 mg per month, no 4 mg per year. Just one single infusion once a year. That is one. Oral, what are the oral drugs that you can use? That's it.
Pamipronil.
Yeah, alendronate is needed. What is the dose of alendronate? 70 milligrams once a week. Side effects of alendronate, why is it not? It's 1 out of 4. Severe gastritis, esophagitis. Okay, so this is one class of drugs. Then next class of drugs for management. Okay, what is denosumab?
Rank and like.
Yeah. How is it different from the bisphosphonates and which one? What is the
Bisphosphonate acts in osteoclast inhibitor,
right?
function of osteoclast inhibitor, and the denosumab is rank and ligand, which prevent attachment of rank in osteoclast, so that osteoclast function is inhibited.
And dose of denosumab?
So 60 mg or 120.
60 micrograms. Yeah.
Subcutaneously every 6 months.
Every 6 months. And how would you compare the two? Zoledronate versus denosumab?
Denosumab these days are used as
Loudly.
denosumab is being used as first line in CKD patients rather than
Yeah, in CKD. But in idiopathic nephrotic syndrome, I think without any doubt,
this.
looking at cost benefit analysis also, zoledronate is one. But, alright. So this is about bone disease and how follow-up DEXA scans, how frequently would you do? So you've done one, you've started the treatment, then next one would be
6 months.
6 months, yeah. Not before 6 months. Okay, so we finished bone density. Long-term outcomes of membranous nephropathy, like what is this percentage that will develop chronic kidney disease?
1/3 of the patient develop chronic kidney disease, 1/3 spontaneous remission, and 1/3 response to treatment.
Immunosuppressive therapy. Now, can let's say this patient is getting chronic kidney disease and you're going in for transplant. Can it recur?
Yes, sir, 50% recurrence.
50% of all. If you look at all recurrences, where do you place membranous nephropathy? Which is the commonest disease to recur?
FSGS.
FSGS is the commonest. So overall, if you look at the nephrotic syndrome, if you look at all patients who are with glomerulonephritis to recur, the recurrence rates are very good. It's less prevalent as far as it is. And which are the patients of membranous who are more likely to recur?
Messaging back.
So, resistant membranous nephropathy.
The
Which
immunological ones, anti-PLA2R, these are the ones. Nobody knows about thrombosplendium because we don't have enough patients, but anti-PLA2R definitely is the immunological ones that are more likely to recur. Alright, so let's say that, we discussed membranous. Now let's say in this patient, the biopsy was FSGS. So what is your prescription now?
Steroids, because he is having
How much, how long?
1 milligram per kg
Okay.
per day for till the patient responds, or because after taking total duration of therapy is 6 months.
Okay. Then let's say 16 weeks this patient has not responded or has developed side effects much earlier. Then what is the second line drug? Then
Calcineurin inhibitors.
yeah. And what are the response rates with steroids? If you look at all FSGS, how many are steroid responsive and how many are steroid?
So around 60%.
Yeah, about 1/3 are steroid resistant. That's what I remember. And then we are using CNS. So let's say what about CNIs in membranous nephropathy? Are there any studies?
So yes, Starman trial, tacrolimus followed by rituximab was compared with cortisone regimen.
Right.
But it shows in CNI there is fast remission, but there is more relapse.
More relapses. Good. Alright, so let's say this patient had FSGS, is gone into, end-stage kidney disease, you've done a transplant, and there is a recurrence post-transplant of FSGS. What's the therapy then?
Plasmapheresis.
Okay. How many sessions, how long, any alternative therapies?
5 sessions.
Okay.
Cycle.
5 may or may not respond, that is what you're telling is more for an antibody-mediated rejection. But all these patients require continuous plasmapheresis. Any other therapy that has been tried in recurrent FSGS?
Rituximab,
Rituximab is coming up very well. We don't have randomized control trials yet comparing the two, but at least there are enough case series available that 2 doses of rituximab give you reasonably good remission. In terms of recurrence of FSGS, can we predict which are the patients with FSGS who are likely to recur post-transplant?
So steroid resistant and early onset.
Steroid resistant. What do you mean by steroid? Early onset means what? Under 6 years of age, if there are. Then steroid resistance. In fact, patients who were steroid responsive and developed progressively. What about genetic markers? Let's come to the genetic markers.
Apol1
Okay.
African ancestry.
Yeah. What are the other proteins that have been implicated, genes that have been implicated in
Nephrin, podosin, informin.
So if you have any of these, what is the risk of recurrence? They don't recur. So these patients do not respond to your immunosuppression. That's the bad news. So if you find any of these genetic markers, the first thing you will do is you will stop immunosuppression. They will progress to end-stage kidney disease, but they don't recur post-transplant. So it is actually the steroid responsive ones who develop secondary steroid resistance over a period of time. And if you have a faster progression over 3 years, then these patients tend to recur more often. In histopathology, some of these studies have shown that if you have the severity of the mesangial proliferation in the native kidney biopsy also predicted recurrence. Age of onset we discussed, under 6 years, that also predicted recurrence. Yeah, I think we are pretty much done. Anybody else, any queries about
Sir, I want to ask about anticoagulation, prophylaxis anticoagulation. In this case, if we want to start any anticoagulation, which anticoagulation we prefer?
We discussed, if you see, so this patient had, what was the risk profile of this patient, you tell me?
Albumin was
1.7.
And if EC ratio is more than 10, it is also
Yeah, but severe, the hypoalemia is a greater risk factor. Some studies have said 2, some have said 2.5. So there is no doubt that this patient would require anticoagulation, and warfarin is still there is not enough data on the NOACs.
Yes, sir.
We don't have enough data yet. That's what you are trying to say.
Yes, sir. So, the time the history part, when we were giving the possible differential diagnosis, so one syndromic diagnosis was nephrotic syndrome. At that time, sir, could we say that it could be a simple CKD as one of the syndromic diagnosis till the history part? So,
There was no history of generalized weakness, easy fatigability or nocturia. No signs of, no symptoms of CKD, chronic kidney disease. But patient may present.
You can present, yes. I mean, some of this, your point is well taken. There, if you can elicit in the history, if you want to get the CKD out, it's good to ask the patient pointedly that, why your renal function is normal. So if you bring that in your history, then you can safely, tailor your case towards a nephrotic syndrome.
so because like we discussed also that like if it would have been an FSGS, it would be that already the patient was in end stage, though she said and the urinary features or else usually would be there. But so sometimes it is said that it would be slowly progressive CKD which can present in such presentation. There is just edema and protein.
So the history, the duration here would favor a nephrotic syndrome. If it's a longer duration, definitely that would favor you. The second I would use by, just ask the patient that serum creatinine, because otherwise it becomes so vast, and if you don't want the examiner to, like if you are well prepared for membranous, then you tell for a nephrotic syndrome, you want to take him towards, so say that, the patient said that the creatinine was normal. And the other reason is the biopsy was done here. So, that also would be a relative pointer that there was a normal size kidneys and all.